a year there?
Correct. So I spent 19 years at Doctors Hospital, then we moved to Larkin Hospital 13 years ago, developing the new radiosurgical unit called ZAP, and also another fancy machine called high-frequency ultrasound to treat the movement disorders.
You've noted that you have a number of professional memberships. I don't want to go through all of them. I'd like to point out a few. Are you a professional member of the American Association of Neurological Surgeons?
Yes.
Are you a member, a fellow American of the College of Surgeons?
Yes.
Are you a member of North American Skull-Base Society?
Yes.
And is that brain-related?
It is.
Are you a member of the Society for Neuro-Oncology?
Yes.
Are you a member of over, or at least 34 different professional memberships?
Yes.
In your career, have you engaged in research?
Yes.
Has that research focused or centered on brain injury?
Yes, it has.
Is some of your research as a principal investigator for THAM treatment of brain tissue acidosis in severely head-injured patients?
Yes.
Did that research and as a principal investigator help you in your diagnosis and treatment of brain injuries?
It actually was in the treatment of severe head injuries, patients who were unconscious, the concept of trying to relieve the increased intracranial pressure that occurs from the injury and to increase blood flow, thereby increasing oxygen to the brain.
Did you also serve as principal investigator for research for the PEG SOD in severe head injury?
Yes.
Could you describe that very briefly?
Basically the same, one of the biggest problems in brain injury is the fact that blood flow ceases to exist as the brain swells up. And so one of the things we try to do is preserve the neurons by making sure that they have enough oxygen and blood flow to them. All these are agents that try to assist that.
I won't go through all of your research and principal investigator roles, but I want to ask you about one more. And that is, did you serve as principal investigator relative to the IRB protocol for brain pathology?
Yes.
And what did that do? What was that about?
It was about looking at what happens after a brain injury to blood vessels and tissue as the intracranial pressure increases in the brain.
Have you been part of publications of a number of different books?
Yes.
I won't list parts of all 16 books, but can I point out a few?
Sure.
Were you the author of a book chapter regarding head injury, difficult medical management?
Yes.
Were you the author of a book chapter on pediatric neurosurgical emergencies?
Yes.
Were you the author of a book chapter on complications of head injuries in adults?
Yes.
Were you an author of a book chapter, Imaging of Craniocerebral Trauma?
Yes.
Were you an author of a book chapter in Emergency Room Assessment of the Head Injury Patient?
Yes.
Were you the author of a book chapter, Intracranial Injuries?
Yes.
I won't list or ask you about the other book chapters that you've been the author of. Have you been involved in journal articles?
Yes.
I'd like to ask you just about a few of the 70 journal articles that you have published.
Your Honor, objection.
So go ahead and ask the question without a comment first.
Were you an author of a journal article, Intracranial Pressure in Non-Traumatic Ischemia and Hypoxic Cerebral Insults?
Yes.
Were you the author of a journal article, Post-Traumatic Cerebral Infarction?
Yes.
Were you the author of the journal Fractures of the Clivus?
Yes.
Could you tell me a little bit about that paper?
We used thin-cut CT scans to identify fractures of the skull base. Prior to this, prior to CT scans, it was very difficult to actually identify radiologically a skull fracture with plain X-rays. The idea was to see if we could identify them more clearly, and so we classified them and delineated them in the paper and discussed the outcomes that were relative to those type of injuries.
In the last journal article I'll ask you about, were you the author of a journal article regarding acute traumatic midbrain hemorrhage?
Yes.
Were you the presenter in a number of presentations regarding head injury and brain injury?
Yes.
You've listed 93. I'll ask you just about a few. Were you a presenter in fractures of the clivus, clinical and radiographic features?
Yes.
Am I pronouncing that correctly?
Clivus.
Thank you. Were you the presenter in acute head injury?
Yes.
And a separate presentation, fractures of the clivus, classifications and clinical features?
Yes.
Do you lecture?
Yes.
Do you have peer-reviewed publications?
Yes. That was one of them.
Thank you. And are you heavily involved in clinical research?
Right now, my research is more based on radiosurgical techniques and outcomes.
Over your career and your study and your clinical experience, have you treated different types of brain injuries?
Yes.
Are you familiar with a number of different types of brain injuries?
Yes, we still treat them.
Were you asked to review materials relative to this case?
Yes.
And do you recall the materials that you reviewed?
Yes.
Could you share with us some of the materials that you reviewed?
I reviewed the chief medical examiner's assessment of the case. I reviewed pictures that I'm assuming the medical examiner took of the autopsy. And I reviewed the report from the forensic pathologist.
And before I ask you about your review of specific materials and your opinions in this case, is there a benefit to your clinical experience in studying brain injuries as opposed to the experience you had as a fellow simply with pathology?
Well, I think that for the jury to understand is a clinician understands the process from the time the injury occurs till the patient either leaves the hospital or dies. And it's a process. And as a neurosurgeon, I have a tremendous amount of experience with that, if that's what you're asking me.
Yes. And so, doctor, you reviewed a number of items of information in this case. Did you have an opportunity to review photographs of a laceration to Mr. John O'Keefe's head?
Yes, I did.
With the court's permission, I'm going to ask to display Exhibit 160.
Okay.
Dr. Wolf, I'm going to ask you to take a look at this photograph. Have you seen this photograph before?
Yes.
I want you to explain to us what you're seeing here and take us through the process of your observations.
Well, what we're seeing is an approximate 1.5 inch laceration with bridging tissue and contusions and abrasions. To us, that's just a classic blunt trauma injury. There's nothing other than just vanilla about it. This is what happens when soft tissue hits a solid ground. The skin tears apart a bit, but not through and through. As you can see, there's the bridging. You can see all the bruising or contusions and just the tear, a little bit serrated along the edges.
Thank you. If you could take that down. Dr. Wolf, as a result of that wound, did you have a chance to further look at information provided to you about the actual inside the skull of Mr. John O'Keefe?
Yes, it was the pictures that I was reviewing showed a non-depressed skull fracture extending linearly through the clivus and into the frontal fossa of Mr. O'Keefe, over the orbital roofs. He had fractures along the temporal fossa as well. So it was a classic linear basilar skull fracture.
Is basal skull fracture a
It's
characterization?
basically the base of your skull is what it encompasses. So the opening at the very bottom is what we call the foramen magnum. That connects your brainstem to your spinal cord. And then as your brainstem goes up, it goes into the different skull areas that, talk about what we call the cerebral cortexes, your occipital lobe, your temporal lobes over here, and then your frontal lobes.
So can you walk us through what happens when someone incurs this type of injury to the back of the head, how it happens, and what are the next steps for a person?
So what happens is, you fall backwards, and the linear acceleration starts to take you back down with gravity. The skull hits the ground. It gets, in layman's terms, smashed a little bit. And then the brain moves forward as a response to that. And it moves forward because you have cerebral spinal fluid and because you have the deceleration, acceleration again. As it does, your skull, if you were to look inside your skull, it's like mini mountains along your temporal bones and your frontal bones. So the brain is being thrust forward at a fairly good speed, and it's getting bruised. You can think of it as if you took a hammer to your thumb. It's really turning black and blue. Those are the contusions. And so the temporal poles and the frontal poles are getting contusions because of that. At the same time, you have a space called the subarachnoid space. And I'm sure they're going to hear about the subarachnoid hemorrhage. And that space is it's very clear, thin membrane that covers all of your brain and all of your spinal cord. And normally, you really don't see it unless you open up the brain and you're operating. But when you either have a traumatic event like this, where little vessels are pulling apart underneath that membrane, or, for example, the classic, when you have an aneurysm burst, the space that the aneurysm bleeds to is the subarachnoid space. The other thing that occurs in trauma like this is you can get a subdural. So the dura is the membrane that covers the whole brain and also right down your spinal canal. And it's a very thin membrane that looks like very thin leather. And in that space between the brain and the dura can be a lot of veins that go towards a central vein called the sagittal sinus. And if those tear, you have a venous hemorrhage from, which is not arterial, so it's not quick, but that can develop into a subdural as well. If you tear a portion of your brain as well, and you get a little arterial bleeds, that could create a much faster subdural hematoma. And so when you look at the pathology, the autopsy of his brain, you're looking at a subarachnoid hemorrhage, you're looking at a subdural hemorrhage, neither one of them which was huge or would have required surgery, as well as the contusions that I described in his frontal poles, in his temporal poles, and then the original bang, which was in the occipital area. These are all findings that you would see on a CT scan and an MRI scan without requiring an autopsy if he had made it to the emergency room.
I want to take a step back at the beginning. You said that this laceration on the back of his head was caused by a fall. Could this be caused by a fall landing on hard ground?
Yes, like I said, it's a classic blunt trauma laceration.
Do you have an opinion to a reasonable degree of medical certainty whether this injury, the laceration and the basal fracture, was caused by Mr. O'Keefe falling backwards on the ground?
My opinion is that that's what caused his whole injury.
The pattern of the laceration, Do you have an opinion whether that is consistent with hitting the cold, hard ground?
Objection, Your Honor. Could we have sidebar on that, please?
So I'm sustaining the objection, so no sidebar.
Your Honor.
Do you have an opinion, doctor, about whether that laceration on the back of his head was caused by a particular movement?
Well, the only way he could get this kind of an injury was to fall backwards, hit the back of his head, and then the resulting, energy forces going into his brain, into his base of his skull.
Would that type of laceration require Mr. O'Keefe to have hit a line type or ridge type object?
A ridge type of object?
Yes.
No, I mean, like I said, the tearing of the skin in that fashion, you could look it up, would be just a classic blunt trauma injury.
Is there anything about that injury that would suggest to you it had to have been something sharp or ridge-like to cause?
Objection, Your Honor. Begin request kindly a sidebar on this.
All right, we'll come to that.
Thank you.
So as we were discussing, Dr. Wolf, you said this is a classic fall backwards. Is there anything about the pattern of that laceration that would suggest that there was a ridge or a line type edge that caused that wound?
Not necessarily.
And have you seen, in your experience, similar types of lacerations and breaks caused by falling on hard ground?
Yes, you can see that both in the occipital region. You can see it if patients fall on the, forehead. The skin tears, they're still bridging, and then they get bruises.
Some of your work was in Minnesota.
Correct.
Was it a colder part of Minnesota?
Very cold part of Minnesota.
Did you-
It's Minneapolis.
I'm sorry. Did you often see these type of injuries there?
Yes, I mean, we took care of a trauma center, Hennepin County. Very frequently, patients that are drunk fall down on ice sidewalks and could develop, lacerations in their head, epidurals, which are blood clots above the dura because they fracture a bone in the temporal area and they can get a bleed from a fractured artery. And it happens when people are shoveling snow and have a heart attack and fall backwards. So there are various ways that people fall, resulting in head injuries and lacerations to their forehead or to different areas of their head.
Can somebody suffer this type of injury simply by falling backwards?
Absolutely.
You had taken us through the process of falling backwards and then talked about what happens to the brain. Can I ask you a couple detailed questions about that?
Sure.
When you explained that the brain upon impact then shifts forward and hits the front of the skull, is there a medical term for that process?
Well, the medical term is a coup counter coup injury. So the coup is when you first hit. In this case, it was the back of the head, as summarized by the laceration in the back of the head, and the contusions that the pathologist and the ME found in the back of the brain. And then the brain shifts forward, and as it's traveling at a certain velocity, because it's thrust forward on the floor of the base of the skull, it's getting bumped, and it's getting, again, you can think of it as a hammer hitting a thumb. It's getting black and blue in the areas that are sharpest.
Are there symptoms that result of the process coup counter coup?
This is clinically, it varies. I mean, you can go from anywhere from a simple concussion, where you sort of are unaware of what happened, but you're still awake, you're confused, all the way to, ultimately being in a coma.
Can this type of injury, the coup counter coup, and what you see in the review of your files, could this type of injury happen from an attack by a weapon, like a bat or a hammer?
Well, he did not have a depressed skull fracture. So any focal hit like that would more likely than not have caused a depressed skull fracture. Blunt trauma, the way he had, the assumption, would cause the coup counter coup without a depressed skull fracture.
When the coup counter coup process happens with the skull fracture, does anything happen to the front of the skull?
Well, you're asking me, does the rest, the forces, depending on how hard they are, can generate fracture lines all the way to the anterior fossa. So you can have fractures along the lateral temporal area. You can have fractures along the orbital roof. The orbital roof is very thin, and so those forces can go all the way to that area.
Did you see any sign of orbital fractures in Mr. O'Keefe?
Yes, he had both the ME and the pictures taken, and the neuropathologist mentioned fractures of the orbital roof.
Do you have an opinion to a reasonable degree of medical certainty how those fractures occurred?
From the trauma.
Could you just explain a little bit how that would happen?
Well, as he fell backwards and he struck his head, it was clearly at a very high speed generated by the gravity. The bone, depending on the quality of his bone, the density, then generated forces. There's a certain amount of lateral give, and then you get a linear force going forward. It drives all the way up the clivus and forward into the anterior fossa where his orbital roofs lay. And this is why people like this get what they call raccoon's eyes.
Do you have an opinion whether the brain itself could have caused the orbital fractures?
No. The brain is a soft substance. You could literally put your finger through the brain. we often operate on people fully awake. The brain couldn't possibly cause a fracture. The fracture was caused by the forces generated through that clivus, that middle bone in the middle of his base of the skull.
Do you have an opinion to a reasonable degree of medical certainty whether or not the brain in any way could have caused these orbital fractures?
The answer is absolutely not.
In your study of the records and photographs and in your experience treating these types of injuries, do you have an opinion to a reasonable degree of medical certainty whether or not a person would remain conscious or would be immediately unconscious after the impact of the ground?
Well, it's impossible to know whether he became immediately unconscious, but his injuries were very substantial, and it's more probable than not that at some point he quickly became unconscious and was unable to do functional activities.
What does functional activities mean?
The ability to, get himself up and about would be one of the functional activities. The ability to call for help would be a very significant cortical function. And that's why I was talking about, that there's a variation on the theme from a simple concussion to a severe concussion like this.
If a person does not have functional abilities because they are rendered unconscious, does their body, could it still move?
Yes, this is the interesting thing about our brain. So the cortex, which is the top portion of your brain, can get separated from your brainstem functionally, and what happens then is that your body is not acting autonomically, meaning vegetative. So why does that happen? We think it's because as we were a caveman, and if a caveman became unconscious, as an animal came up to eat it, the animal would touch it. Well, you have these automatic movements. One of them is called decorticating, which is where you draw your arms like this and you throw your feet out. And then a worse neurological situation is when you decerebrate. Now you push your arms out along with your legs. And that would scare off an animal. So we think that over time, genetically, this is what happened to our brains in order to create these. But those kind of movements are not thought processes. In other words, your brain is not telling you, oh, you have pain, go ahead and decorticate or decerebrate. It's an automatic movement in response to pain.
I want you to take us back now to after the fall. Would Mr. O'Keefe, in your study and opinion, have died immediately?
No.
Can you share?
I don't.
I'm sorry.
Yes, I'll tell you. There is very few things that you head injury where you would die, quote, immediately. So if I took a knife and stabbed you in the back of your neck right below your skull and I drove it through your brainstem, you would probably die immediately. If I shot you below your ear and went through and through below your ear and shot through your brainstem, you would die immediately. But traumatic head injuries, you would not die immediately. It's a process. And it's a process of a combination of things. Brain swelling, which takes a while to develop. Decreased blood flow to your brain because you're getting swelling. And ultimately, death of the brainstem that controls your heart and your breathing. And so this is why there is a whole big issue about brain death. When is someone brain dead? Because it's not instant and it can take a long time to be conceived. In these injuries that are very severe that we took care of, there was a high mortality rate. In the linear skull fractures, it was about 67%. But it took time for them to die. It could take days to weeks to months. And also, these people got to shock trauma, so it was a while, whether it was hours, before they were even starting to be taken care of, and yet they weren't dead yet. That's why I don't think it was immediate.
Was there any other observations you made about Mr. O'Keefe or his body that support your opinion that he didn't die immediately?
Well, the medical examiner took pictures of his periorbital area and diagnosed raccoon's eyes. So raccoon's eyes occur because there's leakage through the orbital fractures into the periorbital space. Normally, it takes about 24 to 48 hours to develop. It has been noted as early as 1 to 3 hours, which would make it not immediate.
Could we please have Exhibit 14? Dr. Wolf, could you share with us what you see here in this picture?
So right here, you can see the black and blue that sort of configures, if he had his eyes open, like what we describe as raccoon's eyes, right? And that's not caused by direct trauma to his eyelids. It's caused by what I described as the basilar skull fracture, which went to the anterior fossa, which is right over the orbit here, inside with leakage of blood products into that periorbital area.
You mentioned that starts or takes at least 1 to 3 hours to begin.
Minimally, yes.
You take that down, please. If Mr. O'Keefe had been brought to a trauma center or emergency room, what would the process be in your experience?
Well, he would have been intubated if he wasn't intubated in the field. One of the first things you need to do in a head injury is control the airway. Why? 2 reasons. One, you want to have enough oxygen going to the brain to feed it. And 2, you want to keep your carbon dioxide down because that causes increased intracranial pressure if it elevates. So you want to constrict the blood vessels a little bit. Then he would have had a CT scan immediately in order to assess whether he has a surgical head injury, meaning he needs to go to the operating room to evacuate something, or not. During that process, he's obviously going to be getting medication to decrease the brain swelling. And from there, you make decisions based on his neurological function and what you're, capable of doing to, spare the brain from the rest of the injuries that will result. One of the things that occurs with contusions is, a great medical term is they can blossom, which means they can get bigger. And if they get bigger, they might require surgical intervention to decrease the pressure as well as the volume of the blood that's destroying brain. And so you do serial CT scans in these patients over time, anywhere from every 6 to 12 hours to on a daily basis, depending on what the case-by-case, production of blossoming is occurring.
You mentioned that about 2/3 of your patients who suffer this injury pass.
Correct. What we saw is that in the patients that suffered linear clavicle fractures, 2/3 of them ultimately went on to die, and 1/3 lived.
Is there commonality on how they pass?
One of the common reasons they passed is if they trapped a major vessel in one of the fractures, they would get a significant brainstem infarct, meaning a stroke, meaning lack of blood flow to a very significant portion of their brainstem. And so that was one of the causes of death that ultimately we understood. And then the others died from the increased intracranial pressure that drove the brainstem down through the foramen magnum.
Did you review any materials that talked about or identified Mr. O'Keefe's body temperature when he was treated?
As I recall, his core temperature was 80 when he was found.
Is that significant in the process and development of his injury from the moment he fell and hit his head until his ultimate passing?
Well, hypothermia, he had, I mean, if you define hypothermia, it starts at 95 degrees. Your core temperature is usually about 98, 98.6. 95 is very mild hypothermia. When you get to 82 degrees, you're in severe hypothermia. What happens when you're hypothermic, and I'm a neurosurgeon, but I can tell you that you get into multiple organ failure. Your heart starts to have problems. It can have arrhythmias. You're not breathing. And ultimately, at hypothermia, you also become unconscious and go into a coma-like state. Below 80 degrees, you're probably going to die. So all I can tell you, it wasn't helpful that he had a significant head injury and that he was then found hypothermic.
Is it uncommon, in your experience, for people that suffer this injury to pass within 5 hours?
Well, none of the patients we treated died within 5 hours, but it also didn't mean that we didn't realize that they were going to be in a potentially vegetative state. When someone's hypothermic, you have to warm them up in order to establish a clinical status, meaning you can't declare someone dead with a temperature of 80. You have to warm them up slowly, appropriately, and then reevaluate where they are clinically.
I've asked you questions about whether you had an opinion about Mr. O'Keefe and when he died. I want to ask it in the form of a formal opinion. Do you have an opinion to a reasonable degree of medical certainty whether Mr. O'Keefe died immediately or within 15 minutes?
No, I don't think he died immediately. Neither the hypothermia nor this kind of head injury would kill you immediately in any clinical experience I have.
Dr. Wolf, thank you.
All right.
If I may have a moment, Your Honor?
Sure.
Thank you. May I, Your Honor?
Yes.
Morning, Doctor. I don't think we've had the pleasure of meeting. Welcome.
Thank you.
Sir, can you just describe, you started to do it a little bit on direct, a typical day for you?
I wake up at 4:15 in the morning. I go to my center. I set up patients with frames for their either radiosurgical procedures or stereotactic craniotomies. I go home. I make cappuccino for my wife at 6 o'clock in the morning. and then I get back to work at 6:30 and move on. I have patients that I'm operating on, and I have patients that I'm seeing through the day.
And what type of patients and what type of work? Just in a typical day. What are you doing? What type of patients and what do you do?
It varies. I mean, I see patients with brain tumors. I see patients with hydrocephalus, which is water in their brain. I see pediatric brain tumors. I see subacute and chronic subdural hematomas, post-traumatic. I see patients with strokes that are being misdiagnosed. I see patients with cancer, metastatic disease. I used to see patients with cervical problems. I stopped doing that 2 years ago. I mean, I don't know what else you want me to tell you.
No, that's great. And is that typical day, typical of the type of days you've had for the past month, past few years? Is it generally, without specifics, is it generally?
Correct.
So, none of your typical days, none of the past typical months have involved forensic pathology, have they? You haven't acted as a forensic pathologist in...
I am, if you could have asked that question, very straightforward. I am not a forensic pathologist. I'm a brain surgeon.
Right. And you don't perform autopsies, correct, sir? You're a brain surgeon.
Correct. In other words, I see more brains than the forensic pathologist.
Right. And is it correct to say that the brains that you see are of living people?
Correct.
Okay. So what I'd like to do is to go to a different part of the head than was discussed, but sticking with the decedent.
Excuse me, I didn't hear the last word.
I'm sorry, the topic is going to be Mr. O'Keefe, the decedent in this matter, sir. You testified about raccoon eyes. The medical term for that, sir, is ecchymosis, right?
Correct.
And ecchymosis, raccoon eyes, does not cause a laceration to form on an eyelid, does it?
No.
Are you aware that Mr. O'Keefe had a laceration to the outside area of his right upper eyelid?
I am aware that the ME described that. Yes, sir.
Now, could, Your Honor, I'm going to, with Your Honor's permission, ask to publish what is already in evidence in a moment.
Okay.
Mr. Wolk,
What exhibit number, Mr. Alessi?
we're going to, 165, Your Honor.
Okay, go right ahead.
Thank you. Dr. Wolf, have you seen this photo depiction before today?
I believe I have.
Is it correct that that injury on the upper right eyelid is caused by the application of force directly to that area of the front of the head, again, namely the upper eyelid?
That's possible, yes.
Is it more than possible? Is it probable that that injury was caused by the application of force directly to that area of the front of his head?
Well, an easy answer to that would be is that that's not part of the periorbital ecchymosis.
Thank you, sir. That was exactly going to be my next question. This injury is unrelated to any of what you've been describing, the fall backwards, the force transfer inside the skull, the, as you described it, the dura, the cerebral spinal fluid, all of that dynamic that you so ably described on your direct examination. This injury has nothing to do with that, correct?
Correct.
Thank you for answering my questions. Dr. Wolf, a pleasure again. No more questions at this time, Your Honor.
Any brief follow-up on that?
No, thank you.
All right, Dr. Wolf, we're all set, so we can get you out of here.
Thank you very much.
All right. Mr. Brennan?
May we have a moment to inquire of our next witness?
Sure. And when I see counsel inside our jurors, feel free to stand up and stretch. So, jurors, you may realize that that went quicker than we thought. So we are ahead of schedule. So why don't we take that morning break that we can take? So we'll take a 15 or 20-minute break.
All rise for the court, please. Jurors, close your
That's true, but the poor don't pay taxes. 40% of the American people, not all of whom are poor, don't pay any income taxes. So it's kind of hard to cut taxes for somebody who doesn't pay any. So the charges are misleading. When we passed the tax cuts in 2017, if you go back and look, I think you'll see that by 2018, almost all Americans were experiencing an increase in their family income, and those at the lower end of the wage scale had much higher increases than those at the upper end of the wage scale because the bill stimulated the economy, as will this bill.
Senator, when you're back to committee. Thank you.
Anything else?
No, that's it. Thank you.
All right, thanks, guys.
Senator, can we get your reaction to the new score from CBO that shows the reconciliation bill will add $2.3 trillion to the deficit?
It's not deficit neutral.
You want to see more cuts?
We got to be deficit neutral. I agree with my colleagues. I'm sorry, I'll be happy to come back out and do an introduction.
And what did you conclude in your physical match analysis of those items together?
So, upon examining and comparing item 3-2, 7-12, and 7-14, I had concluded that 6 of the 9 pieces of glass from 7-12 physically fit with item 3-2, and the remaining 3 of the 9 from 7-12 did not have a physical fit to item 3-2. I also compared item 3-2 and 7-12 to 7-14, but there was no physical match to item 7-14.
Now, in addition to that, did you also do a physical match analysis between item 3-2, the drinking glass, 7-12, pieces found from the roadway, and certain pieces from 3-3 from the bumper of the vehicle?
Yes, I did.
And what did you conclude based on that physical match analysis between those items?
So upon examining and comparing those items, so there were 5 total pieces of glass from item 3-3. I used 2 of those pieces for physical match comparison to the items recovered from the road. Upon my examination, I did not, there was no physical match between those 2 pieces from item 3-3 to any of the pieces recovered from the road. So that included items 3-2, 7-12, and 7-14.
Now, as far as the 2 pieces that you had selected from item 3-3, do you recall which of those 2 lettered pieces you chose for your comparative analysis?
Yes.
And which were they?
They were pieces A and B.
And if I could ask, why pieces A and B versus other pieces?
So A and B were used for physical match. The remaining 3 of the 5 were not used for physical match comparison due to their size and condition.
Now, those same 2 pieces from item 3-3, pieces A and B, did you then do a physical match analysis between that and 7-14?
I did.
And what did you conclude from that analysis?
I concluded that there was no physical match between the 2 pieces from item 3-3 to item 7-14.
Now, did you also do a physical match analysis between piece E from item 3-3 from the bumper?
I did not. No, not a physical match examination.
Did you do any comparative analysis between a piece of glass E from 3-3 from the bumper and item 7-14?
Yes, I did.
And what did you conclude from that analysis?
So I selected piece E for further examination. I did microscopic examination as well as instrumental analysis, and I did the same microscopic and instrumental analysis to 7-14, and I compared the data, and I came to the conclusion that the piece that I sampled from item 3-3, piece E, was found to be consistent in physical and instrumental properties to the sample that I took from item 7-14.
If you could, Ms. Hanley, could you please explain to the jury when you say instrumental analysis, what is that? What does that consist of?
So the instrumental analysis that I conducted was on the GRIM instrument, which measures the refractive index of the samples. So after I had ran my samples for both item 3-3 and 7-14, I compared the data to determine whether they were consistent or not consistent.
And so when you say that something is consistent in instrumental properties, what does that mean?
So in this instance, they had consistent refractive indices.
Now, in addition to that comparative analysis for the glass items, what other additional examinations did you perform in this case?
Sorry, could you say that again?
In addition to items 3-2, 3-3, 7-12, and 7-14, what other items did you look at in this case?
So I also examined item 3-1 and item 7-18.18.
And what was the description provided to you in reference to item 3-1?
3-1 was a tail light, and there were also some other plastic pieces as well.
And taillight from the same vehicle as the glass from the bumper, correct?
Yes.
May I approach, Your Honor?
Yes.
You have another single photograph. Do you recognize that?
Yes, I do.
And what do you recognize that?
This is the photo that I took of item 3-1.
Your Honor, the Commonwealth will seek to introduce in a minute.
No objection.
Thank you.
May I publish, Your Honor?
Yes.
Ms. Gilman, if I could have photograph 9394. And Ms. Hanley, do you recognize what's up on the screen as Exhibit 200?
Yes, I do.
And what do you recognize it to be?
This is the photo that I took of item 3-1.
And what's contained in here, is that a fair and accurate portrayal of what the item 3-1, the taillight housing, looked like when you received it?
Yes.
Now, as far as, and we'll get to this more a bit in a moment, but as far as any sort of comparative analysis that you did with any other item, what part of this taillight housing were you comparing to that other item?
So there were clear and red plastic portions of the taillight that appeared to be broken. So I sampled portions of the clear plastic as well as the red plastic on the taillight.
And just for clarity purposes, if you could with the pointer, as far as which of these pieces up on the screen were you sampling the clear and or the red plastic from?
So the red plastic that I sampled was from this area. It's a little hard to tell from here. I think I'd have to refer to my photo in my notes, but I think there were a couple of different areas that had clear broken plastic. I think this might have been one of the areas that was broken that I sampled.
And just for my purposes, really what I'm asking, Ms. Hanley, is the clear plastic that you used from item 3-1 was from the housing unit itself, the large piece, correct?
Yes.
Okay. Ms. Gilman, you can take that down. Now, the other item that you were comparing this to was item 7-18.18. Is that correct?
Yes, that's correct.
And what was provided to you as the description of that item, 7-18.18?
7-18.18 was debris that was collected from two pieces of clothing from the victim.
And specifically, that would be 7-17, an orange T-shirt. Is that correct?
I believe that is correct, yeah.
Okay, as well as 7-18, a gray long sleeve shirt. Is that correct?
Yes.
And when you say that item 7-18.18 contained debris, what did that debris consist of?
So the debris consisted of one clear piece of plastic, as well as several pieces of red plastic, among some other trace material.
Now, were there measurements taken of those items within the debris, specifically the clear plastic and the red plastic?
Yes.
And what were those measured to be?
I would just need to refer to my report for that.
Okay, go ahead.
Thank you. Okay, so the clear piece of plastic in 7-18.18, it measured approximately 1/8 of an inch by 1/16 of an inch. And then I measured the largest and the smallest of the red plastic pieces. And the largest piece of red plastic measured approximately 1/16 of an inch by less than 1/16 of an inch. And the smallest piece among those measured approximately less than 1/16 of an inch by less than 1/16 of an inch.
And so those particular pieces that you measured, about how small are we talking about?
So the largest for the red plastic, the largest piece measured, just for visual purposes, it's roughly like the size of a grain of rice. The rest of the pieces were smaller than that.
And who within the lab provided that debris in that taillight housing to your unit, to the trace unit?
So the debris from the clothing was transferred to my unit by Maureen Hartnett, and the taillight was submitted to the lab by Trooper Christopher Moore.
May I approach, Your Honor?
Yes.
Showing you a series of 5 photographs. You could review those and look up when you're finished. Generally speaking, Ms. Hanley, do you recognize what's depicted in those photographs?
Yes, I do.
And what do you recognize those?
Those are the photographs that I took of 7-18.18.
I'm going to call both the seat to introduce and admit as the next exhibit, A through E.
No objection.
Thank you. It's 201 A through E.
And Your Honor, may I publish?
Yes.
Ms. Gilman, if I could have photograph 9352. And Ms. Hanley, what is depicted in this photograph on the screen?
So this is one of the photos that I took of 7-18.18. This is how I received the clear piece of plastic.
And is that a tin that it's encased in at the time that you receive it?
Yes.
Ms. Gilman, if I could have 9355. And what is this, Ms. Hanley?
So this is a photo of the clear piece of plastic that was within that tin.
And Ms. Gilman, if I could have 9364. And Ms. Gilman, if you could enlarge this just a bit. Maybe just a little more, please. Thank you. And Ms. Hanley, what are we looking at in this photograph?
This is the photo that I took of the debris that was collected from the clothing items.
Ms. Gilman, if I could have 9366. And again, Ms. Hanley, what are we looking at here?
This is a photo that I took under a microscope of the red plastic pieces that I noted within the debris.
And lastly, Ms. Gilman, if we could have photograph 9369. And Ms. Hanley, what are we looking at here?
This is a picture that I took of the red plastic pieces that I removed from the debris.
Thank you. Ms. Gilman, you can take that down. Now, Ms. Hanley, in reference to your comparative analysis from item 3-1, the taillight housing plastic, to the clear and red plastic pieces of debris from debris from item 7-18.18, the clothing of Mr. O'Keefe, what types of instruments did you utilize in this comparative analysis?
Sure. So after completing my examination, I utilized a comparison microscope as well as a polarized microscope, a FTIR, which is Fourier transform infrared spectrometer, and I also used a microspectrophotometer, also known as a microspec.
And what is a microspec?
So a microspec is an analytical tool that we can use to examine samples that have color. So it provides information on the sample's dyes and pigments.
And how is that utilized in your comparative analysis?
So I ran samples from both items that I was comparing, and I compared the data from those two items as a part of my comparative analysis.
And when you run that sort of data, can you describe for the jury sort of what that data looks like? Like what are you physically seeing when you're examining the data from a microspec?
So what we refer to it as a spectrum or just a graph, and when we do the comparison, we can overlay those spectra or graph to determine if they are consistent or not consistent.
And I know you spoke a little bit about it in your testimony yesterday, but if you could remind the jury as far as an FTIR, what is that and how is that used in your analysis?
So an FTIR is another analytical tool that we can use. A sample is exposed to infrared light, and it reacts in a certain way with that light. And what's produced is a spectrum of peaks and valleys that are representative and unique to your sample. And so that instrument was used to run samples from both items, and then the data was compared from both items.
Now, from your comparison of starting with the clear plastic from the debris from Mr. O'Keefe's clothing, from your comparative analysis of that clear plastic to the clear plastic from item 3-1, the tail light, what did you conclude?
So the clear plastic from the debris was found to be consistent in color and instrumental properties to the clear plastic from the taillight. So accordingly, the clear plastic from the debris could have originated from the clear plastic from the taillight or from another source with the same characteristics.
And with reference to the red plastic from item 7-18.18 from Mr. O'Keefe's clothing, in your comparison of that red plastic with the red plastic from the passenger side taillight of the defendant's vehicle, item 3-1, what did you conclude from that analysis?
So the red plastic that I sampled from from the debris from the clothing from 7-18.18 was found to be consistent in color, microscopic appearance, and instrumental properties with the portions that I sampled from the red plastic from the taillight. So accordingly, the red plastic from item 7-18.18 could have originated from the red plastic that I sampled from the taillight or from another source with the same characteristics.
I'm sorry, Your Honor, if I could just hold on 1 minute while the sirens pass. May I approach again, Your Honor?
Yes. Actually, is this a good time to take a break, Mr. Lally? Lunch and break?
Entirely up to the court. I probably have another 3-4 minutes left.
I'm going to see counsel for 2 minutes, folks. Like I told you earlier, we're ahead of schedule, so we will take a luncheon break, and we'll take an hour. So I know we'll take an hour, okay? We'll see you back here. So, we're just going to follow.
All rise for the court, please. Yours, close your notebooks, follow me.
ערב טוב אזרחי ישראל. בשם כולכם אני מבקש תחילה למסור תנחומים מעומק הלב שלי, גם מעומק הלב שלכם, למשפחות היקרות של סמל יוסף יהודה חירק וסמל ראשון דנילו מוקנו, זיכרונם לברכה, שנפלו ברצועת עזה. מלחמת התקומה גובה מאיתנו מחירים כבדים, אבל יש לה תכלית מוצדקת וברורה מאין כמוה. להכריע את החמאס שביצע את זוועות ה7 באוקטובר, להחזיר את כל חטופינו,